Good morning, everyone. Great to see so many bright and smiling faces here at the end of what has been a brilliant and quite long and sometimes arduous meeting. I'd like to introduce this morning's speaker, Ben Davies. Ben is one of our academic neurosurgical trainees and has developed a very impressive CV, which you can see in your program. He's particularly interested in one of the main themes of this week's conference, degenerative cervical myelopathy. He's been co-leading the recode DCM study. He's also involved with the polyfix surgical trial. But after the debate we had yesterday on surgery, whether or not to operate, Ben's going to introduce us to the themes of translational medicine and talk to us about DCM outside the operating theatre. So over to you, Ben.
Thanks very much. Good morning. Good morning. So a little bit of a challenging brief, this one. We were asked to talk a little bit about life after surgery, and it was challenging for two main reasons. First of all, it's the morning session, the morning after the party last night, so thank you to all those who contributed to myelopathy.org last night. But the second challenge is that we don't really have a good lens on life, long-term life after myelopathy, which will break down. So what we're going to go through really in brief is that this is a life-changing disease. We sort of know that. Surgery is not a magic bullet. It is effective, but it's not perfect. We sort of know that. But unfortunately, these patients are left with quite significant disabilities, which varies from individual to individual. It's very often hidden. We don't often see it. And our current care pathways don't really work well to pick up these problems before we can even think about addressing them. So very much as the messages was yesterday, I think this is an opportunity to think differently about myelopathy and ultimately work very collectively, because there are no doubt some solutions from similar conditions. Traumatic spinal cord injury stands out as one, as well as some optimistic long-term bets, including regenerative medicine. So I'm going to be joined in present very shortly by Helen, who you may have met last night, who's the chair of the trustees for myelopathy.org, and in part because myelopathy.org has been a big part of opening my eyes to the bigger problem, and that's been led by a chap I met 8 years ago called Sandler, who alongside Mark Cotter, we set the charity up. And he's an individual with myelopathy, an individual who had great difficulties in being diagnosed and struggling in the aftermath of that disability. And as we put this charity together really as an information platform, we started to meet many more people with myelopathy long term, and saw that Ewan's story very sadly isn't a unique one, and that's really inspired all that followed really. And I think there's a triumvirate we share, essentially this. We are complete suckers for all things and challenges myelopathy, and you can buy one of these very overpriced mugs on our website, all for a good cause. And if you recruit 10 patients to Polyfix, I will buy you one. So anyone who signs up to that, that's also fine. So let's start with a little bit about what we actually know. And I think we should start by looking very simply at what the surgical care pathway is. And this is a bit tongue-in-cheek, but in a nutshell, it looks like this. Patients are referred to specialist services. You confirm the diagnosis of myelopathy, or you dismiss it. You then make a decision about should I operate and probably how. And they go through surgery, and they probably get one follow-up appointment. And certainly in my lens and that follow-up appointment is essentially to see whether you've made any problems. And if you haven't, you recognize that patients don't get better, and it's onwards and upwards for them and goodbye. And that's about it. And if you look at the evidence, that's pretty much all that we've thought about. So in terms of the short-term expectations, we can see that about 12% of patients will deteriorate with surgery. Generally, that's explained by adverse events or a comorbidity. Lumbar canal stenosis is certainly something that crops up in this patient group. But there is a small proportion that we don't get to the bottom of. I think that's worth recognizing. But overall, the clear evidence now is that surgery is a cost-effective treatment for myelopathy. And you can see that the outcomes are generally modest. There are a few people who make quite significant gains. This is called the MJOA score on the bottom there. Maximum score is 18. Meaningful clinical differences between 1 and 2 points. So there are gains, but it's not total normality. And in terms of recovery trajectory, which is data that's come out quite a lot recently, it's actually quite quick that they're going to get back the gains if they're going to get them back. And this on the left is data from the CSORN registry, which is a big Canadian spine registry, and to be honest, is like the BritSpine registry, but seems to be being put to very good use in terms of understanding what's going on. And you can see on the left there that essentially the gains are all happening by that first follow-up appointment at 3 months. There's very little trajectory beyond that. And I just showed a little bit of data here on the right, which is a big landmark trial a couple of years ago called CSMS, a randomized trial of anterior versus posterior surgery. And I show it specifically really just to highlight that there are possibly some nuances to recovery profile depending on the surgery. You can see in this data that the dorsal surgery has a slightly delayed recovery peak at 6 months against anterior surgery, but ultimately the gains are in the short term, mid-term if you like, and not the long term. And then the final bit we think about is the long-term reoperation rates. And again, really good quality long-term data is generally missing, but it's a small proportion of patients that come back. It's certainly higher anterior than posterior, and there's the big debate, obviously, particularly if you go outside of the UK, on disc replacement, which we won't get into. But that's about all that we know. And of course, the problem is behind all of that, there is great impact. I think on a global level, less than 5% of patients are getting back to normal scores on these outcome measures. There's high levels of dependence and unemployment. That's our data. There are different data from different data sets, but it's high level. And in terms of impact, we try to compute that into societal cost in the UK. If you add in sort of cost of treatment, loss of productivity, loss of taxes, increased social disability payments, then it's costing the UK about £0.7 billion as a societal cost each year, which is huge, and that's just the tip of the iceberg. And a final thing, getting back to our talk here about this being a lifelong condition, I think this is a very simplistic way of trying to answer that question. But essentially what we've done here is look at the life expectancy of people treated for myelopathy. It's a follow-up, long-term follow-up of over 300 patients from the early 2000s, late 90s. And you can see against age-matched healthy controls, which is the red line, these patients are dying younger. And what's particularly interesting about that data is it seems to be driven by disability. So if you look at who recovered well and got back to mild disability, then their life expectancy is normalized. Those who remain disabled ultimately have a shorter life expectancy. And that's obviously a little bit logical, but ultimately, importantly, shows us that we need to think more about how we apply our surgery in order to get these patients back to normality. So I think the big questions around can we do better and how we approach this. And this is something that I was shown recently actually from a business perspective, which is, I think, interesting parallels for us in surgery. And it's a business model called the core product and the product surround. And the idea is that you have as a business your core product you're trying to push and sell, but ultimately the majority of its success is dictated by how that interfaces with the environment, how you personalize the product, deliver it to market, the aftercare, the sales, the communications. And the criticism is that companies overinvest in the core product at the expense of the product surround to their detriment. And they hold up examples such as, why MySpace lost to Facebook, et cetera, But it's very easy to transplant surgery into the core product there, and then to see that we are very similar, perhaps, in how surgery could be optimized in terms of its impact. And a lot of that, we do think about in terms of who we should operate on. But there's probably much, much more that we could be doing. And I just want to introduce another concept that we've been working on from Cambridge, which is to think a little bit differently about the disease. When we were getting very involved in this about 8 years ago, we were really struggling to reconcile what we saw in the clinic with this definition of myelopathy being a compressive injury of the spinal cord. And essentially we know that because if you look now, as more and more imaging studies are done, spinal cord compression in the neck is actually 10 times more commonly asymptomatic. So these are three very similar individuals in terms of the amount of cord compression they're suffering from, three very different clinical phenotypes. So on the far left, no symptoms, middle, bit of sensory disturbance in the fingers, and they've even got signal change there, as you can see. On the right, they're in a wheelchair. And ultimately, therefore, compression doesn't define whether somebody has the condition. It doesn't really dictate how bad the condition is, and it certainly doesn't dictate response to treatment. So if it's not compression, what is it? Well, we started to look at this. Really, it's quite conceptual at this stage with some early data, but I think the idea we have is that ultimately compression is one loading mechanism, and it's probably quite short-lived, and actually there's a much more complicated cascade set off in terms of what is loading and injuring the spinal cord. And ultimately this is what surgery is to undo, this sort of driving force. But ultimately the stress itself doesn't dictate the disease, and there seems to be a complex response of the body to that stress, both at the level of the spinal cord, where as a chronic process the mechanical stress will be injured and repaired in a constant cycle that needs to be overloaded to cause structural damage, and ultimately your body's adapting to that injury. It doesn't want to have symptoms, and it will have some resilience to that before it develops a symptomatic DCM. So there's this idea of vulnerability that is increasingly broad in terms of what we think about, but conceptually are things like aging, genetics, nutrition, and all sorts of features such as that. And this is a causal diagram that we're thinking about now in terms of how you modify and control for data in trials. But essentially, it looks quite complex and interactive. And I think it just shows that, you take away one part of the mechanical stress, and there's still many more things to think about in terms of optimizing our treatment paradigm for myelopathy. So it comes back to the equation and the idea that, yes, we have a core product doing one bit, but what about the product surround? So another sort of signpost really to ideas about how this is approached. And this is a field called systems engineering. It comes from really engineering practices about how you optimize efficiency in systems, and it's being applied increasingly to healthcare. And this is a group, again, from Cambridge who designed a sort of paradigm for how it's applied to healthcare. But once you've had an idea that maybe we should be doing something differently, the starting point is to understand the problem before you think about solutions, test, and ultimately look at their durability. And so if we come back to myelopathy, how do we start to think bigger than what we currently see in our small pathway? And the lesson that I've learned is you have to start with the patients. They are the people who are the constant throughout the journey here. And for that, I thank a pre-recorded video from Ewan.
Hi, I'm Sandler, a person living with DCM and co-founder of myelopathy.org. My journey with myelopathy began in my 30s with muscle aches and neck stiffness. I was a busy married father running a sign and design business and training regularly in jiu-jitsu. I just assumed I was getting older. Unfortunately for me and many others, discovering the name and the seriousness of my condition took many years. Alone and unsupported, I had to navigate a maze of doctor's appointments, seeking answers that seemed totally out of reach. Meanwhile, I kept on pushing my body through the physical demands of my job and my active lifestyle, unaware that I was only making things a lot worse. The unbearable muscle spasms and pain were a constant battle. My body was sending distress signals, but no one knew the cause. I struggled through 14 years of doctor's visits and numerous trips to A&E before someone finally linked the problems to my neck. This felt like a relief, finally an answer, and with surgery, surely a solution. But I was totally unprepared for what would follow. I underwent surgery and had an anterior cervical discectomy and fusion from C4 to C7. I was discharged home after only 2 days, barely able to swallow. I ate only Weetabix for 3 months, with no rehabilitation or advice on what to do or what to avoid. And at my single follow-up appointment, the surgeon considered the operation a success. But I had gone from an able-bodied, active, middle-aged and married man to a divorced, unemployed and disabled one. My independence and purpose had been taken from me. I was only 44. Getting stuck in the bath and needing to call my mother to help me out was a new low. Some of the problems I would eventually learn to live with. I could walk with a stick and I could use my computer again. But many other problems my doctors were unwilling to acknowledge. The chronic pain, the unexplained muscle twitches and spasms, and the fatigue. This didn't help at home. The doctors say the operation was a success, Ewan. Why can't you get back to work? My now ex-wife would say. Hitting rock bottom motivated me to find a new path. It led me to start an online peer-to-peer support group, which would become myelopathy.org. Here, I found thousands of other people in the same position, asking the same questions. Should I have surgery? And what can I expect from it? Why do I feel like this, despite having surgery? Does it mean it's happening again? Are there any treatments or lifestyle changes that can help? How can I access financial support, or why has it been declined? Why has my doctor never heard of this condition? Living with myelopathy is a mystery to healthcare professionals, and this needs to change. I remember a charity member telling me she'd been dismissed from a spinal cord injury community as a walker. Perhaps we look different, but we face similar problems. Aftercare and support are readily available for people with traumatic spinal cord injuries. Don't people realise that myelopathy is also a form of spinal cord injury and way more common? Myelopathy causes lifelong and hidden disabilities. Through trial and error, I found some strategies that help. Meditation and mindfulness, for example. This tells me there are some simple gains to be made by recognising this as a lifelong condition. I urge you all to raise awareness and improve care pathways for myelopathy. Thank you.
So that's Ewan, who has been a real pioneer in setting the charity up and ultimately promoting a bigger think again, work together message. And I think, very recently we had an individual come to the charity who actually was an anaesthetist from the US in his early 40s, who had a very similar story. He's medically trained, and over the course of 6 years he lost the ability to work, an ability to never get back again. And in the UK and US, you can imagine the income situation for him is absolutely transformational difference now into what he has now for the rest of his life. So this can affect anyone, could affect somebody in this room. And let's unpick some of the things that Ewan's picked up on there, because there are some easy messages that we started to think about as we listened to Ewan and people like Ewan very similarly. And the first is, don't we tell them that they're not going to get better? That's usually a core part of the consent process, the expectation. And, I would certainly assume that we do. We're usually quite pessimistic as doctors, trying to, sort of prevent any over-optimistic attitudes. But certainly in a study we've recently completed, quite detailed interview study with 20 patients, I think the answer is that if we do, they're not remembering it as they leave the clinic. And I think reflecting on these challenges, I think what these patients face is quite a long journey to get into our specialist clinics. They're being seen and worked up by people who are very distant from DCM, who have very little appreciation for the condition. And it means that they enter the clinics not knowing anything about the disease, still the optimistic viewpoint that they're probably going to be cured. And in that clinic, which is a one-off thing, you've got to go from that huge knowledge gap through a treatment paradigm to an expectation management paradigm. And I guess they're simply not leaving the room with the right information. And these challenges are compounded by the fact that around the world there is very little information support for these patients, and that's really what led to the origins of the charity, and something that we'll touch on a little bit later. A lot of the resources, if they exist, are very targeted around the procedure, which I think is unhelpful in terms of looking at life after the disease. Radiculopathy after an ACD is a totally different beast to myelopathy. I think this is a very simple area for gains, and we'll touch on this a little bit later, but something that we could simply and easily do tomorrow much better. The second thing is, isn't myelopathy painless? If you look at a lot of textbooks, they talk about myelopathy as a painless condition. Pain, if it occurs, is radicular or driven by the arthritis of the spine. And again, this is something we've started to unpick over the last 5 years, that actually that is an oversimplification. This all started when we started to define our own regenerative medicine trial about 8 years ago, 10, maybe longer now actually. And we wanted to understand what to measure in that trial, what should be the primary endpoint. And we did a very simple survey of almost 500 people living with myelopathy. The majority had been through surgery, and we asked them very simply, what would be the recovery priority? What would you most like to have resolved? And the overwhelming majority of patients chose pain as their recovery priority, ahead of dexterity, ahead of walking and balance. And, I guess when we started to think about why that is, we were quite surprised by that result. Probably the simple answer is we just hadn't been asking the right questions. If you look at the data and the trials, pain is very infrequently measured as an endpoint. Because of that precedent, we think it isn't there. And 25% of studies between those 20 years that even measured pain is often in a very simplistic fashion. And on the back of that, as we started to build and question that result, we got a lot of pushback on the idea that pain is a part of the biology of myelopathy. People have started to show that it very much is. This is a re-look at the big Spine data sets, and very clearly there is a burden of pain, it's neck pain measured here, that responds to surgical treatment significantly. And a different way of looking at this, a chap called Chad Cook's recently gone through a very large insurance registry in the States and talked about something called high-impact chronic pain. High-impact chronic pain is a new definition from the NIH in the US, which essentially reconciles high-intensity pain with disability and day-to-day life activities. And they found that in that population of almost 600 plus patients, over 50% have got high-impact chronic pain. And that's actually above the intensity levels you see in back pain, which is quite surprising. And yes, again, surgery is very effective at mitigating that. The majority of patients respond well, but some don't, and some actually go from a no-pain state to a high-pain state. So it is certainly a burden that is there, and something that can, I think, be very disabling. And we've looked at, in a very sort of detailed cohort, of people who report pain about their experience, and I think the safe message is that this is not neck pain. This is a whole-body, complex neuropathic pain, which is probably beyond the comfort zone of certainly me as a surgeon, and is something we should be looking to integrate more with other specialists. And finally, anterior surgery, isn't that better? And certainly the paradigm shift for places like the UK, and the US, Canada, I've shown US data here, is to shift practice to anterior surgery where possible. And I guess the premise here is that from our experience in the operating theatre, our experience in the hospital, these patients go home faster, they report less pain, and so it must be better. And there are certain parts of the world where the complete opposite is thought. If you look at Japan versus the US here, Japan is almost exclusively operating from the back of the neck, and predominantly with laminoplasty, which you very rarely do in the UK. And this brings me back to this phenomenal trial published a couple of years ago now called the CSMS trial, which is phenomenal for a number of reasons, but foremost because they randomized anterior versus posterior surgery where there was equipoise. And they used a multidisciplinary panel of surgeons to review cases and agree there was equipoise in order to make that randomization. And they've got very robust data now to 5 years of outcomes. And the take-home overall message is that there is no difference in anterior versus posterior surgery. There's possibly some nuance in the recovery trajectory. This is shown here on this graph, which you saw a little bit earlier. But also there's some nuance in the impact in terms of adverse events, the type and the profile and the frequency. And what this trial did in a different way to many others was carry out a very detailed analysis of dysphagia. So picking up on Ewan's point, what they found is that the adverse event rate was much higher in the anterior group than the posterior group. And actually they did a subgroup analysis here of laminoplasty, which you can see. And overall, laminoplasty fared better than posterior fusion. Obviously, this is the States, there's no laminectomy on all the others. But the big burden of that anterior surgery is dysphagia. And that's problems persisting if it occurs beyond 6 months in about half of events. So it's well beyond our follow-up point, and it's something that I never even thought to ask, to be honest. And I challenge you to go back and ask your patients, and I suspect you will find these problems when you ask them. And interestingly, people are thinking now a little bit differently about this. This is a lady called Anna McDowell. She's a spine surgeon from Sweden, and she's also conducting a very similar trial to polyfixed DCM in Sweden. And her perspective on this has led to her to have a complete paradigm shift in her approach. And she's gone from a very anterior-driven practice to now a very posterior-driven practice in laminoplasty. And in her data, she has halved her adverse event rate, halved the reoperation rate, and ultimately probably saving some money. Now, we can't obviously do posterior approaches always, but I think this is a complicated situation now where we no longer have, default positions, and it's ultimately got to be optimized to that individual circumstance. When we set these priorities, and I haven't got a link right now, but if you look on the Spine podcast, you'll find an episode about a gentleman who's blind, and he had a largely anterior-driven pathology, and had a lot of surgeons tell him, I've got to go anterior. And he was like, the only thing I have in my life is my singing. I don't want to lose my voice. Can I not go from the back of the neck? And he eventually persuaded someone to do that, and he made a full recovery with a single posterior approach. So I think this is a complex discussion now, which increasingly needs more evidence, but is ultimately where surgery as a decision-making process needs to move. And then finally, Ewan mentioned that he didn't have any post-op care, and I know in our institute in Cambridge that is a pretty ad hoc, pretty sparse provision of this sort of thing. The spinal cord injury centres sadly aren't interested really in this, unless it's really, really severe, and I guess that's a capacity issue more than anything. But it's also not supported by the fact there is zero evidence for rehab in myelopathy post-operatively, and I guess until you unpick that question, then people aren't going to take any note that there could be some benefit. But logically, it certainly seems that way, and that was the perspective in our research priority setting process where we defined that as a key knowledge gap. So I think the experience that I've had is that, if you're not careful, you see this with a very microscopic view, and there's actually a much bigger problem that until we characterize, ultimately, we can't even think about trying to solve. And that's another way of expressing the same viewpoint. So this is my oversimplistic view of the lifelong care that somebody with spinal cord injury, traumatic spinal cord injury, receives in this country. So you think about trauma, there's an operation, but then they get this inpatient, perhaps outpatient, but long-term specialist integration services, commissioned, etc. It doesn't exist in DCM. We have this very small microscopic view and a black box around it, and I think that's something that needs to change. But let's move on a little bit to myelopathy.org, because I think in terms of education and support, there is simple gains that can be made tomorrow for your patients. And I'm going to hand over to Helen, the Chair of Trustees, to introduce a little bit to what we can offer.
Good morning. So I talked quite a lot last night, if you were at the dinner, about myelopathy.org, and this is something that can really help both you as clinicians and, most importantly, your patients. So we are an education and support platform. So what we would suggest is when you first see a patient, you should introduce them to myelopathy.org. We've recently just produced a postcard, which some of you have seen, which is downloadable from our website, which you can print out and physically give to your patient. It's very simple, and it just is a signpost for them to our website and our support groups. So it gives them the information that they need, which they can access in their own time and at their own pace. So this is the homepage of our website. We also have a huge peer-to-peer support network, which was set up by Ewan. This now has the private peer-to-peer support group now has about 3,000 members worldwide. It is not just a UK-based platform. It encompasses an enormous number of people in America, in Australia, and also in other places around the world. So that postcard also would signpost your patient to that peer-to-peer support group. This is a private group, so people can meet online via Facebook and ask questions, have questions answered by other people with DCM. So it is very much the people with DCM helping other people with DCM. Last year, one of the members of the support group, Esther Martin-Moore, decided that as the COVID restrictions were easing and people that she'd seen much more of when everyone was doing Zoom meetings and coffees and drinks parties, etc., when people who weren't disabled suddenly started to re-enter their normal lives, she found that she became completely isolated. So she asked Ewan, could she set up this virtual coffee mornings for people with DCM? And so Coffee with Esther was initiated. And this has become, both in the UK and in America, a hugely valuable support system for people where they meet by a Zoom meeting and have a coffee. It happens, I think there are 3 meetings a month, both in different time zones, so lots of people can access this resource. And the anecdotal feedback we've had is this is incredibly valuable to people. And also, Esther felt she'd lost her purpose in life, and she started to volunteer for myelopathy and set up this support network. And she now says when she meets people, she feels she can say, this is what I do. I volunteer for myelopathy.org, and I help other people with the condition. she doesn't feel that she's lost her identity and her purpose in life. So very, very simple things like this can really help the individual patient. So what can you do? As I've already mentioned, we have our little postcard that you can download. It's on our website, which was, the recent iteration was launched on Monday in time for BritSpine, so please do take a look. There's a lot more information on there now than there was previously. Also in your clinic letter, please insert a link to the charity so that both your patient knows about it, but other healthcare professionals who will read that letter will also become aware of it, and so we can spread the word. The charity is also, as you will have heard over these last couple of days, we also have the Recode Research Network, which we are running as well and managing. So this has 1,000 members now as part of the Recode DCM, and so that's another thing that you as healthcare professionals can get involved in. Take a look at the research section of our website, which is all new, and see if there's a way in which you'd like to become involved and reach out to us via the website. Liz Roberts, who is here this week as well, who some of you will have met, is our project manager for Recode DCM, so please do contact her. As Ben has also mentioned, Chad Kirk, the professor of physical therapy at Duke University in the States, is leading the perioperative incubator group. The incubators, we're planning to have 1 incubator per top 10 priority, and at the moment we have 3 running. But for this, the relevance for this lecture is the one that Chad is running. And we also always want feedback. What can we do to improve what we provide through myelopathy.org and the support that we provide? So please let us know. We need your feedback too and your input as to what we can do better. We are always open to new ideas, and as we increase our resources, we'll be able to implement more of these ideas. So email me, that's my email address, please, and let us know what we can do. And we want to work cooperatively and collaboratively with everybody, both the patients and the healthcare professionals, so we can all work on this together. Thank you very much.
So please feel free to get your phones out and have a little browse of the websites. It's pretty fresh. We've got a new update and it's looking very good. Spanish translation coming shortly. If you speak another language and want to help us translate it somewhere else, please let us know. There's enormous things that I've taken away from the experience with the charity. I think the one is huge unmet demand. When we first started this, you Googled myelopathy and you found canine myelopathy, which, because this disease is quite common in dogs, but is of absolutely no use to you as a patient. But the second thing is that there is a huge burden of patients out there who are physically disabled but not mentally, and that means that they're unemployed, but they're also time rich, and we've been able to give a lot of them purpose. There's been a very strong volunteer network which has ultimately grown this charity. I think Esther is a prime example of that. I think Mark touched on this a little bit yesterday, but the bringing together of people who can understand each other in that very different way is incredibly powerful. And we're not the first to say that support groups like that are a good thing. We know that from all sorts of healthcare, but we are the first to try and bring that together in myelopathy. I think one of our challenges is we are pretty small, and ultimately this is all virtual. So the patients who don't have access to the web, apps, etc., it's a bit more difficult to engage with at the moment. But hopefully, with time, that will change. But the other thing I took away from these experiences was that ultimately, talking is a therapy. If the psychiatrist can make a whole business of it, then why can't we add it to our armory? And we started to think a little bit about how we could operationalize a more structured therapy around content education. And it's still very early days, but I want to introduce you to a project we've had funded called Shared DCM, which really helps to move to a position where we have very optimized shared decision-making in this condition. I talked about the obvious decision that we see all the time about surgery and that need to move to a position where it's very individualized, contextualized. And this is where shared decision-making as a principle has its biggest gains. But I think ultimately there'll be lots of courses around the pathway where there is not clear-cut binary decisions to be made, where this sort of process is important. Before you can enter a conversation around shared DCM, the person that you're talking to ultimately needs to be able to understand the disease. This is the model of shared decision making, which essentially means you need to prepare the patient to engage in that process, i.e. educate them. You introduce choice, you offer the options, and then you're involved in identifying their priorities and having a discussion. But it's that preparation phase here which we've started to focus on in a particular way. And I'll just show you a short video about the concept that we're working on called a core information set.
People with DCM must make many choices about their care, choices that will define the rest of their life. Should I have surgery? What type of surgery is right for me? But this often comes immediately after the diagnosis, about a condition they have never heard of.
Sir, you have degenerative cervical myelopathy.
None of this is ideal for good decision making.
Before anything else, preparation is the key to success.
Usually, in everyday life, we are primed to help make good choices, even in pressured situations. Think of a flight. Every flight starts with a carefully chosen and standard piece of information about aircraft safety to ensure we are prepared to make good choices should a pressured situation arise. At myelopyorg, with the support of the Evelyn Trust, we are working to identify exactly what information a person with DCM needs in order to make the right choices for them. We have identified a long list of DCM information from scientific publications, general media, and community interviews. We now need your help to decide which of this is the essential introduction to DCM. What would someone need to understand to make the right choices for them? Once we have this, we can share this through clinics across the world as the DCM core information set, a carefully chosen and standard piece of information to ensure people with DCM can make good choices, even in a pressured situation. Visit info@myelopyorg to get involved.
So that's the concept, and as you can see, I've imagined myself with lots more hair in that video, which is also the beauty of animation. But this is what the project looks like, and essentially it's a consensus process. You know, we've worked very hard to understand the information needs, what patients, professionals think needs to be transferred in this process. And we're now prioritizing that in a Delphi process that will hopefully essentially produce a checklist that a patient could bring into the clinic, and you can make sure you covered everything, or you could help to structure a conversation. I was on a webinar with the North American Spine Society not long ago, and there's this great Texan surgeon, very direct, as you can imagine, and he described patients with myelopathy as clinic crashers, because suddenly you go from a very efficient, smooth-running part of your day to suddenly, boom, 1 hour spent with one individual. Totally disrupts the whole flow of everything else. And I think that is, you know, an area, therefore, not just gains, but efficiency, if we are very selfish about it. And I think something like this could potentially help that process, and certainly can be operationalized in lots of different ways. And one of the partners for the charity is actually a group from the University of Sydney, led by David Addison, who's a physio in Sydney. And they are trying to operationalise not just the preparatory phase there, but the whole process of shared decision-making around surgery, particularly for mild DCM, which, if you joined the talks yesterday, is clearly an area where there's lots of uncertainty. And it's very early days. This is a prototype of what a decision-making aid might look like. It's about to be tested, and we'll hopefully to jazz it up and make it a little bit more attractive, but again, ready to integrate into clinics around the world. So that's a moment to pause, really. There's a little bit more we can talk about in terms of, you know, what ideas are out there about helping people recover, which we can touch on for a few minutes in a minute, and I would love to introduce our regenerative medicine trial from Cambridge, but I thought I might just pause there and welcome any perspectives on your practice, you know, your location, what you do, what works well, what you find are the challenges, and because ultimately I think, as I said, this is about thinking differently, working collectively. There are lots of opportunities here.
Great, thank you, Ben. While just waiting for some questions to come forwards, maybe I'll make a comment and ask a question. I think we all work in a constrained capacity, but we can't use that as an excuse. And that was a very eloquent talk, thank you, and focuses us on priority on this patient group that maybe, you know, is not getting the best standard of care. In our units, I think many units, there's specific Cauda equina clinics, and you could ask why many of us don't have specific myelopathy follow-up clinics. Just as a surgeon as well, you touched there on mild DCM, and we know some of those patients will stay fairly stable and some deteriorate. And in a system of constrained capacity, that can be stressful. And certainly we can sometimes let patients down who deteriorate on a waiting list. And we've had a very good talk on that theme at this meeting. As a clinician, I just use a blunt tool, the MRI scan, not terribly predictive, as you've shown, and a clinical examination. Can you look into the future and tell me what markers or what other information may be available to help me predict which patient may deteriorate?
Yeah. How to break that down? I think what we're going to find is, we're currently writing a paper on it, but if you break down that causal model that tries to understand what we think myelopathy looks like, the purest signal you can find on the disease is probably the rate of change. And so if you can accurately track the longitudinal change in these patients, you're going to understand, I think, truly the implications for them as an individual. And that's one. And I think at the moment, the tools we have in clinic don't really do that. You know, the exam doesn't change, the MRI doesn't change. We haven't presented it very much here, but in Cambridge, we've been building an app technology, basically, which integrates wearable data, integrates interactive tasks and assessments on the phone, which I think give a much more powerful time-average remote assessment of myelopathy. And I think that is something that we hope to push into the clinic and can be quite transformative. We're actually talking to the British Spine Registry about integrating it into the outcome assessment for the spine registry, so hopefully in due course more to come. But I think rate of change, if we can get a good lens on, is the really critical thing. And at the moment we use rate of change in a subjective way. The patients say they're getting worse. We're led by the patients, because I think if you miss the boat, you've missed the boat, and that is ultimately too late. And you bring up a great point, and I think it comes back to education. You know, the pathway for surgery lists them, puts them on a waiting list, and then you don't know what happens to them. So they can totally change, particularly with stresses and strains on systems, to the point where they come and they just think that they've got a treatment on the horizon, and they don't realize they've got, 10, 20% worse, and they arrive 10 weeks later, and ultimately, again, ship has sailed into very different positions. So I think educating them on, what to look out for, when to ask for help, is a really critical part of that process. And I wanted to just to touch on, again, one other final thing, which I think, again, is technology we're working on in Cambridge, which I think could be helpful. And essentially, again, if you look at the causal diagram that we're starting to think about now in myelopathy, for surgeons particularly, I think a key thing is to be able to understand from the MRI how the spinal cord is being injured. The MRI is, you've got to remember, the spinal cord is a soft vasoelastic material. We move it all the time as surgeons, and it's fine. So a disc slipping out and touching the cord, compression-wise, isn't really necessarily an injury, but it's a complex thing. It's moving. They might have variable moments of subaxial movement. It's oscillating. And therefore, we're starting to take the MRI and turn it through finite element analysis into a picture. It shows you exactly how much it's loaded and where. And I think that will help translate a little bit about what the condition is. Because if you can really understand how the spinal cord is being loaded and how much, you ultimately dictate the value of your surgery, because that's what you undo. So I think those are some ideas in a very conceptual way. But I think short-term rate of change, big thing to think about.
Thank you, Ben. Yes.
Ben, Omar Gabar from Leicester. Very inspiring talk. I'm going to download your nice little postcard for my patients. But one of the things that you mentioned earlier, that high-impact cervical pain. And when I see my patients, one of the commonest things you find in your past medical history, they've already been by rheumatologists, even treated by polymyalgia. They're diagnosed with polymyalgia. And how many of the patients you've observed that actually were diagnosed as that? And maybe that's the group we should be targeting to picking them up at that area.
Yeah, no, I 100% agree. And I think particularly fibromyalgia as well, isn't it? I mean, yes, I don't know. I mean, I think the uncomfortable thing is that it's, now we've realized the MRI is okay, but not perfect. We've got to go back to resorting to clinical acumen to make a diagnosis. And when it's obvious, it's obvious. And when it's not, it's difficult, isn't it? These patients have soft signs, pain, is it a pain burden they're seeing? And I think the challenge is, to your question, we don't know the answer. I suspect there is a big area of misdiagnosis there. But it's the comfort then of being able to go, yes, surgery is a great idea for you.
Yeah.
Knowing a little bit of the characteristics of those sorts of patients and the sort of chronic disease burden they already have. And that's the discomfort that I personally feel at the moment. And we take an approach of very trying to carefully watch them for a while and be confident, again, ready to change, that this is something that is a myelopathy as well as a complex pain.
I was just from Ian's experience, so he suffered from it for 10 years, getting lots of aches and pains, and it probably will be put on steroids, which probably will make some improvement, because steroids as an anti-inflammatory, and it probably reduces some of the impact of that repetitive injury.
Yeah. Yeah.
But I think there's a group there that's misdiagnosed.
Yeah, I think so. I think a lot of these specialties, I think look at the diagnostic pathway, about half come from MSK now, about half neurology, and there's about 5 to 7% in that from rheumatology. And I think, unfortunately, with the history of how this has been managed, there's a lot of poor feedback loops. So we've told them the MRI is normal, and then therefore they've learned that means there's no myelopathy, and we haven't started to see these patients anymore. So I think there's a lot of re-education with our colleagues to make sure that some of these potential candidates that we need to unpick are finding their way to us as well.
Thank you.
And we've got time for just one more question, and then we'll have to finish
Yes,
the
no problem.
session. Go ahead.
Yes, Himanshu Sharma from Plymouth. Excellent presentation and great place for myelopathy.org. So there are few issues which we all come across. When we look at myelopathic patients, there are diagnostic as well as therapeutic challenges we see. Now, first is a delay in diagnosis is not because there's a couple of comments I'm making, and you see average time is around about 5 to 6 months, and some places it could be even more. And most of the patients in the 60 plus, they believe, if they're clumsy hands and unsteady gait, it may be just age, and they just don't report early on.
Yeah.
And radiculopathy patient, they have a lot of pain and they present quite early.
Yeah. Yeah.
Now, if you look at, that's one side of the delay in diagnosis. Other side is where you have a variety of causative factors, like, say, for example, degenerative cause of soft disc prolapse, which is very rare, maybe 1 or 2%. With myelopathy, they may give you great results. But on the other hand, if you have OPLL, on the other extreme,
Yeah.
whatever you do, the results are very sort of dismal or may not be as predictive.
Okay, we might have to close the question off there.
When you see
Do you want to
patients-
summarize with a question for Ben?
So the question is, if you have patient with stenosis, where there's no cord signal, the patient has more symptoms, and otherwise you have abnormal cord signal with very minimal symptoms, and how do you sort of manage those patients?
I think we could have that debate all day, couldn't we?
Yeah.
Probably. I think in short...
Ben, I think we need
we'll
to
leave it
close
there.
the session there. But
Okay, no problem.
thank you so
Thank you
much
very
for your eloquent presentation. Much appreciated.